Good evening. Welcome to Medicine in Our Backyard. This is a series presented by the Newport Beach Public Library Foundation. I'm Adrienne Windsor. I am on the board of the foundation, and so it's my pleasure to welcome all of you here. Our last Medicine in the Backyard program will be on May 20th, and that will be the last one for the 2018-19 season. It's on UCI Men's Health and Sleep Medicine Services. I don't know if that includes, I shouldn't say this, but it seems like every other ad is on erectile dysfunction. So I don't know if they talk about men's sleep, if they're going to talk about that. But maybe if I say they will, you'll all come, right? So that will be Dr. Fazil Yafi and Bruce Mender. Mike and Polly Smith are not here tonight, but they are the benefactors of this series. They were actually the initiators of this series. Several years ago, I happened to be at the meeting when that happened, and it's been an extraordinary series for us. So a quick bit about the foundation. How many of you are members? Quite a few, okay. We're sort of silent partners with the library. We provide funding for things that the city does not provide, and oftentimes you may not notice, but you're sitting on chairs that were provided by the foundation. The media lab was provided by the foundation. If you need a computer upstairs and you get beeped, that's something that the foundation did. So we appreciate memberships. We're a membership organization. We support the Witty Lecture Series in the Library Live series, as well as this series. So if you aren't a member, we'd love for you to become one. Now our program tonight will include Q&A. So what we would like to do is to ask you not to ask questions during the presentation, but to hold your questions until afterwards. And if you haven't silenced your cell phones, would you please do that now? And then I get to introduce our wonderful speakers. But before I introduce them, I'd like to introduce Kari Consul, MD. Would you please stand, Kari? She's been at UCI for a short time. She's a board-certified UCI Health surgical oncologist, and she is here in Newport Beach. And she's going to be answering questions at the end of the program with our two speakers. So welcome. We're happy to have you here. Now, our two speakers, Dr. Erin Lynn, she's a board-certified surgical oncologist. She specializes in breast health promotion and breast surgical treatment at the UCI Health Family Comprehensive Cancer Center in Orange, and the UCI Health in Yorba Linda, and she's kind of moving her full-time practice up to Yorba Linda. She earned her medical degree from Western University of Health and Science in Pomona. After completing a residency and internship in general surgery at Arrowhead Regional Medical Center, she completed fellowship training in breast surgery at UC Irvine School of Medicine. So that's pretty extraordinary. Our second speaker, and actually he's our first speaker, is Dr. Freddie Combs. He's a UCI Health board certified radiologist who specializes in the detection and diagnosis of breast cancer. He's also board certified in family medicine. He received his medical degree from the University of Arizona College of Medicine. He completed an internship and residency in family medicine at Phoenix Baptist Hospital in Arizona, followed by a residency in radiology at the University of Arizona. Do you realize how many years these people work to be able to do what they do for us? It's really extraordinary. We have to commend you for your persistence and your discipline, as well as your brilliance. So anyway, Freddie completed a fellowship in breast imaging at UC Irvine, and tonight Freddie and Erin will be speaking to us on the update on breast cancer screening and treatment. So join me in welcoming them. You're welcome.
Thank you all for coming out. I appreciate it. I see some familiar faces from our clinic, so thank you guys for showing up and supporting us. I'm going to try to go through the basics of breast cancer screening just from a perspective of what it would be helpful as a patient to know. I like to think of my patients as being informed consumers. I want them to feel empowered and understand what screening can and can't do. So we'll go through this, and hopefully we'll shed some light on how we approach finding breast cancer. So why do we screen for breast cancer? Well, this has been a debate. Some people say we shouldn't screen. Some people say we should screen at different intervals. There's a lot of controversy out there. So why all the fuss? Well, a teacher that I had during my residency summed it up best. He said, because it's out there, man, it's out there. Breast cancer is out there. And we'll talk about some important statistics here. 1 in 8 women in their lifetime, and actually 1 in 1,000 men will get breast cancer. In 2018, there were nearly 300,000 cases of invasive and non-invasive breast cancer in the United States, and approximately 40,000 deaths. So I like pictures. So that's the Rose Bowl. It holds 93,000. So we get about 3 Rose Bowls worth of people diagnosed each year. It kind of puts it in perspective. And that's Angel Stadium, which holds about 45,000. So that's about the number of deaths that we have each year. So when you look at it like that, it is a disease that, regardless of what you do in life, you're going to encounter it. Some more important statistics. It is the second most common cancer in U.S. women, only behind skin cancer, and it represents 30% of all breast cancer, or all cancers diagnosed in women. There's currently 3 million breast cancer survivors in the United States. Only 15% have a family history. 85% have no family history. Most breast cancers are not genetically linked, and oftentimes people will say, well, I don't have any family history, so I'm safe. That's not true. Starting with anatomy, I think it's easier to understand why we do what we do when we screen if you have a little bit of understanding of how the breast works. It's pretty simple plumbing, basically. You have a area called a lobule, and lobules drain into ducts, which drain into the lactiferous sinuses and out here. This is where the secretions are made. They're made in the lobule. And each of these are called lobes. So there's about 15 to 20 lobes. Each lobe ends up in a duct in the nipple. So breast cancer anatomy, invasive ductal carcinoma. So most breast cancers start in the duct. A smaller portion start in the lobule that I just described, but invasive ductal carcinoma represents about 80% of all breast cancers, whereas invasive lobular carcinoma only about 10%. So this is the basic pathophysiology, or how breast cancers tend to develop in the duct. So this is what a normal duct looks like. It's generally got a single-celled epithelium. When that starts to overgrow, we call that hyperplasia. When the cells start to become abnormal, we call that atypical hyperplasia. When the cells turn cancerous and start to fill the duct but have not broken out, we call that in situ carcinoma, or ductal carcinoma in situ. We abbreviate that DCIS. And then when the horse gets out of the barn, that's when it becomes invasive ductal carcinoma. And this is cancer breaking through the duct wall. So that's the most common type. Risk factors. We tend to think of risk factors as being genetic and environmental. We subdivide them in breast imaging into non-modifiable and modifiable. So things we can change and things we can't. You can pick your nose, but you can't pick your relatives, right? Female gender. These are the non-modifiable risk factors. Female gender, age greater than 45. Gene mutations, here's a few of them. BRCA is the one we talk about the most, or the breast cancer gene, but there's many others. Having a family history or a personal history of breast cancer, and then menstrual history. When you start your period as a young woman matters, and when you go through menopause matters. So the earlier you start your period and the later you go through menopause, the higher your risk. And it has to do with the number of uninterrupted cycles in your lifetime. So it is linked to the cycle. Other non-modifiable risk factors include dense breast tissue. We'll talk about that in a little bit. You may hear that term a lot. It's been talked about quite a bit. Hopefully I'll be able to clear up what exactly that means here in a little bit with some slides. High-risk biopsies, something called lobular carcinoma in situ or atypical cells. If you think back to that slide I showed before, where the cells become abnormal, we call those atypical cells. Those put you in a higher risk category. Previous chest radiation, and then other benign proliferative breast lesions such as things called papillomas, radial scars, things like that put you in a higher risk category. So things that we can change, modifiable risk factors. Nulliparity, or having no children. Again, it goes back to number of uninterrupted cycles in your lifetime. And also late parity. If you have your first child after age 30, it increases your risk. Having children early, in your 20s and earlier, actually reduces your risk. Obesity, body mass index greater than 25 in a postmenopausal woman puts her in a higher risk category. Alcohol consumption, more than about 2 to 3 drinks per day. Hormone therapy, combination therapy with estrogen and progesterone postmenopausally has the highest risk increase. And then I put these as red because physical exercise and breastfeeding actually reduce your risk. If you breastfeed for a sum total of about 12 months lifetime, it actually lowers your risk. So those are things you can do to decrease your risk. I need to work on this one. So how do we evaluate risk? I think it's important for patients to know where they fit on the risk spectrum. And there's computer-based models that we use to do that. It's based on a lot of factors: family history, menstrual history, pregnancy history, ethnicity, and previous breast biopsy results. That all gets factored into these computer programs, and they'll estimate your lifetime risk. By creating a risk profile, it allows us to customize screening for patients. Back when mammography first came on the scene, you would show up, you would get your mammogram, and that was it. But now we can stratify people based on their risk into getting additional screening tests as indicated based on their risk. And we'll talk about how we do that in just a minute. So the model that I use is called IBIS. There's several models out there, but that's the one that we use. And this is kind of a small slide. I'm sorry if you can't read this, but this is the printout that we get on each patient. So it tells you what the risk is after 10 years compared to the population risk, what the lifetime risk is, what the lifetime compared to the general population, and the probability of a breast cancer gene mutation. So it gives a pedigree, and then here's the patient's risk relative to the general population. So why is screening important? Well, since we started screening in the 90s, there was a giant decline in breast cancer mortality to the tune of about 30%. And this is taken from CDC data, but you can see this is adjusted mortality rate per 100,000 people between 1992 and 2010, and it's pretty dramatic. And really the only thing that changed is we started doing mammograms regularly. That makes us happy. Lots of pink things in the breast cancer world. So screening, it all starts with the mammogram. That's what it's all about. That's the gold standard for screening. It's been studied extensively, and it is the only study that has been proven to reduce the mortality rate. MRI is really good, has a really high sensitivity for detecting cancer. Ultrasound is also very useful, but again, neither of those have shown a reduction in mortality from breast cancer. I think eventually, as MRI comes around, it'll start to prove to be on par with that, but it's not there yet. So right now, mammography is the best we got. So this is a mammogram. This is a basic screening mammogram. We do 4 views. We compress from the top down, and we compress from the side. This is the top-down view. This is the right breast. This is the left breast. It's like you're facing the patient. And this is the side view with the chest muscle here. We try to keep the nipple in profile. The darker tissue is fatty tissue. The brighter tissue is glandular tissue. And this is what makes up dense breast tissue. So I'll show you a slide here in a minute that gives a breakdown of the different types of breast density. So who should get screened? Well, this is a hot topic. There's lots of different guidelines out there. Just about every different organization has their own set of guidelines, and they vary. I use the American College of Radiology guidelines, and the reason why is I feel like they're the most comprehensive. They find the most cancers. Start at 40. I think that's the key. A lot of the more aggressive breast cancers occur in younger women, and some of the screening protocols don't start until 50, and you're writing off 10 years there. So I think at least have a baseline at age 40. In some women who are higher risk, we might start earlier than that. For example, women with a breast cancer gene mutation or a known genetic disorder like Lee-Fraumeni or Cowden syndrome, we might start them screening at age 25 with mammography. Once you have a history of breast cancer or ovarian cancer or any high-risk lesion on breast biopsy, you should start screening then. It's not very common to find those things in women in their 20s, but occasionally we do. And then, as I mentioned before, chest radiation, women who received mantle radiation between the ages of 10 and 30, we start screening 8 years after the radiation treatment's done. That's when we start to see cancers related to radiation show up, is about 8 years after the last radiation dose. We try not to start before age 25, though. So for breast augmentation, this is Newport Beach. We have lots of implants floating around here. Guidelines are the same. It doesn't change. It's still yearly. It does require a higher level of skill to do a mammogram on an implant patient. So find a place that's ACR certified and does a lot of them, which they're not hard to find around here. There's lots of really good breast centers in town. Ours is the best. What age does screening stop? There's no upper age limit, so screening can go on indefinitely. What we say is, as long as the patient is in good health and is willing to undergo additional testing, including biopsy, if an abnormality is detected. I have plenty of 90-somethings that are in great health, and there's no reason why you should let a small breast cancer slow them down. So I encourage them to get screened. But again, that's an individual's choice. Most of the studies that we have only go to about 75, so the data gets a little iffy after you get past 75. But still, I'm a fan of screening as long as the patient's willing. Okay, so when do we need to do additional tests? I mentioned before that we try to cater our screening to the individual patient based on their level of risk. So what I do is do a screening mammogram and then take a history, apply that IBIS computer program, and get a number, a risk number. So in general, a risk of 0 to 12%, we consider that low or average risk. Intermediate risk is 13 to 19%, and high risk is 20%. What that number means is that's their lifetime likelihood of getting cancer, so 20 years, or 20% over their lifetime. And then we assess breast density on the screening mammogram, and that may lead us to doing ultrasounds. And we'll talk about that. So if a patient's level of risk is 0 to 12%, we do a screening mammogram and consider doing a screening breast ultrasound if their breasts are dense. The reason why we do that is it's harder to read dense breast mammograms. So I like to have a backup of a secondary study. For intermediate risk, screening mammogram and screening breast ultrasound if dense breasts. And then for high-risk patients, in addition to the screening mammogram, we recommend screening breast MRI or ultrasound if they're not able to have an MRI. So what does breast density mean? So in a nutshell, California passed a law in 2012 following several other states. I believe it started in Connecticut, requiring us to notify patients when they have dense tissue. So it's a great idea because a lot of people don't know that they have dense tissue, but the problem is there's no consensus on how to approach that. So you tell somebody they have dense tissue and they go, oh my gosh, I have dense tissue, what do I do? We don't know. But dense breast tissue does decrease the sensitivity of mammography. It's much harder to read a dense breasted mammogram than normal density mammogram. It is assigned based on the mammographic appearance and not on exam. A lot of physicians sometimes will do exams and say, boy, this patient has really dense breasts. But actually we do the mammogram and that's not true. So based on the way a breast feels, doesn't necessarily correlate with its density on mammography. So we describe these 4 different types of breast tissue. We call this fatty, and you can see it's mostly the dark tissue, mostly fat. We call this scattered fibroglandular, where there's more glandular tissue, but it's kind of scattered throughout the breast parenchyma. We call this heterogeneously dense, and this extremely dense. About half the world fits into one of these 2 categories, and about half the world fits into one of these 2 categories. So about half the world has dense breasts. And you can see reading this mammogram is much easier than reading this mammogram. I used to have an instructor from Sweden who used to say, you could hide a Volvo in that breast and I wouldn't see it. So breast MRI, let's talk a little bit about that since I mentioned it for higher risk screening patients. It has a very high sensitivity for detecting cancer, about a 95% sensitivity. When a cancer is there, MRI will see it. So it's a really powerful tool. Mammogram can see some things that an MRI can't, so it doesn't replace the mammogram. They actually work really well together, especially with dense tissue. So there's no radiation. Something that people always ask is, well, isn't that MRI giving me a lot of extra radiation that I don't need? There's no radiation with an MRI. It does, however, require an IV. We inject intravenous contrast. So here's some pictures from our scanner. The beauty of MRI is we can really subtract a lot of things out. This is the heart and chest wall. This patient actually has implants, but we can subtract those implants out and just see the tissue. This is a little cancer right here that we found sitting right on the edge of the implant that you could not see on the mammogram, but it just jumps right out on that MRI. This is a patient with a breast that's near completely replaced with cancer. But those pictures are pretty dramatic and pretty helpful in terms of trying to find small cancers. And here's another kind of a classic cancer sitting in the middle of the breast. It actually kind of looks like a crab, which is where cancer got its name. Ultrasound. So ultrasound is one of my favorite tools. It's only as good as the holder of the ultrasound probe, though. So it does require an extra level of skill. A good ultrasound tech is worth her weight in gold, or his weight in gold. Somebody told me if you have a good ultrasound tech, kill him before you let him quit. So ultrasound is most effective as a diagnostic tool. We use it way more as a diagnostic test than a screening test. And what I mean by that is a diagnostic test is for evaluating a symptom. If somebody comes in and says, I have a lump, that becomes a diagnostic exam. If there's no symptoms and we just do a screening mammogram or a screening ultrasound, that's a screening test. So it's the preferred imaging modality in younger women or women that are pregnant or lactating. We try not to radiate pregnant women, and women who are lactating, we try not to radiate lactating tissue, plus you can't really see much through a lactating breast on mammogram anyway. Ultrasound's a really good adjunct to mammogram for women with dense breasts, like we mentioned before, and it's excellent for biopsy. Much easier to do a biopsy with ultrasound guidance than it is MRI or mammogram guidance. A lot of people think, well, MRI is so high-tech, wouldn't an MRI-guided biopsy be the way to go? I'd much prefer to do an ultrasound biopsy over an MRI-guided biopsy, just for accuracy. And these are some ultrasound pictures. So you can measure blood flow with ultrasound, and this is a cancer that we found in a young woman, and you can see how vascular that is. Cancer tends to have really rich blood supply. And this is what a typical cancer looks like on ultrasound. Cancer tends to kind of chew its way through the tissue, and it's really dense, so not many of the sound waves get through it, so we see this shadowing underneath it. So what you're seeing here is you're seeing the chest wall here. This is the pectoral muscle, and skin is up top, so this is the breast tissue. And this is a cyst. This is probably the finding that we see the most, and this is benign. It kind of looks like a lemon or Charlie Brown's head, but that's a good guy. So tomosynthesis, the new kid on the block, 3D mammography. There's really been a lot of talk about this since it came on the market, and it's really started to replace conventional 2D mammography because it's so good. I was really happy when we got our 3D machine a few years ago because it really allows us to see things that we could never see before. So it combines multiple mammogram images to reduce tissue overlap. So what it does is it takes pictures in an arc, and then we can reconstruct those in a slice-by-slice basis and get a three-dimensional picture. It improves what we call a callback rate and cancer detection. So if you come in for a screening test and there's a finding on it, we typically will call you back for additional imaging. That's what a callback means. When 3D first came on the market, it reduced our callback rate between 15 and 20%. And it increased the cancer detection rate in some studies by as much as 40%. It requires only slightly more radiation, and actually the radiation dose is getting better and better. Mammography is not a very high dose radiation entity anyways. It's pretty low dose. If you take a plane flight from LA to New York, you just had a mammogram. If you walk around on the earth for a year, you had about 7 mammograms worth of radiation from the sky and the ground. So as far as radiation goes, it's not like a CT scan, which is more on the order of about 100 times more than a mammogram. It is more expensive, but as I mentioned, it's gaining acceptance of having significant benefit over conventional 2D mammography. So this is what a 3D slice image looks like. This is a 2D picture here, and you can kind of see maybe there's a little something there, but it really jumps out on the 3D image, and this is a cancer in the left breast. And here's another demonstration. Again, 2D picture, 3D picture. Pretty dramatic. Okay, so now I'm going to talk a little bit about barriers to screening. Why doesn't everybody get a mammogram? Well, there's a lot of reasons for that. Some of it's the internet, some of it's personal belief. There's a lot of misinformation out there. People often don't understand what their risk is. Again, like I mentioned before, they think, oh, I don't have a family history, I'm safe, or yeah, I really don't feel a lump or anything, so I think I'm okay. Another thing that creates a barrier is poor communication of results, and that's on us. I think over the years we've done a poor job of really having women understand what they're getting and what that means. We're trying to change that at our breast center. We try to give everybody same-day results so they don't have to go wait for a letter. If there's an abnormality, we try to address it that day. I will generally sit down with patients on their first visit, let them know what their risk is, let them know what their breast density is, and hopefully through information increase their knowledge and their awareness about what screening can and can't do. Also, lack of timely follow-up or delayed reporting and results. So how do we break down these barriers? Well, we create a new understanding of breast cancer. 30 years ago, breast cancer was a really fearsome and gruesome disease, and almost everybody had an aunt or uncle or cousin or somebody who knew somebody who had a really horribly disfiguring surgery and then died a horrible death. But we don't see that much anymore. It's become more of a chronic illness because we're getting so good at finding these cancers so small. Also, advances in surgical technique and medical oncology and radiation oncology have really led to improved outcomes. So breast cancer is not necessarily something to be feared as much as it is to be respected and tested for. So our goals. We try to reduce fears, like I mentioned, by giving same-day results. We try to educate our patients to be informed consumers. I want my patients to know what their risk is. I want them to know what their breast density is. I want them to be able to ask their doctor, hey, I have dense tissue. Should I be getting a second study? What do you think about that? I'm high risk. Do I need genetic testing? Do I need an MRI? Those are all questions that I think just through a little bit of education we can really answer for patients. So we try to minimize the time from diagnosis to treatment. When I first started, the surgeon that I worked with was Dr. Alice Police, and she's since moved to New York. But Dr. Police and I decided that we were going to see how quickly we could take somebody from diagnosis to treatment. Well, she was experimenting with a couple of newer technologies for intraoperative radiation, which actually will give you radiation at the time of your surgery. So we had a patient that came in on a Monday, had a screening mammogram. There was an abnormality. We did an ultrasound, found that abnormality, biopsied it, Had her follow up with Dr. Police on Wednesday. She did her preoperative consult. It was a tiny little cancer. Took her to surgery Friday, had intraoperative chemotherapy, or intraoperative radiation, and theoretically was done with treatment. So Alice used to joke and say, "What did you do last week?" "Oh, I had breast cancer," and now it's gone. So I think we have the capabilities to practice like this, we just don't, and I think we need to move towards that. There's just too much information, and people are too savvy now not to be able to address their needs quickly. Utilizing a team approach is key. At UCI, we meet once a week. All the physicians, medical oncologists, surgeons, plastic surgeons, pathologists, myself, radiology. We all meet and talk about all of our cancer patients to make sure everybody's on the same page and that everybody is following the same program. So things like that are really helpful to patients, and now Dr. Lynn is going to tell us how she fixes them once we find them. All right.
Alrighty, thanks for the early introduction. This is just a slide that shows I have no financial disclosure. I only have some financial burden of 4 kids. Thank you for Julie, Sally, and really convinced me to be here. And I'm a surgeon, just like Dr. Cancel. I typically like patients to be quiet on the table. And we're now really good at talking and we're giving speeches. But also thank for Dr. Freddie Combs, and he was the attending physician, taught me a lot. Maybe a couple slides I borrowed from you. And thanks for Dr. Carrie Council to be here and supporting me. And also thank for lots of volunteers put their time here, and also my patient. Those are the most important people that give me the courage to be here and to spread our information. And I think Dr. Freddie Combs mentioned it takes a team approach to treat breast cancer, but most important thing you will notice, breast surgeons' role becomes smaller and smaller because there are other treatments. So to lighten up the lecture, I want to show you a little bit of a picture. I took my college son to do a few medical mission last year, and those are the picture at this is Guatemala, and we have a little young merchants over here. We have local people, and that's his mom and his little sister. We also have our bodyguards and traveling with us when we do surgeries. And those are our OR tables, the sink, and those are the gauze that have been used multiple times, and those are actual OR anesthesia table. Everything is in the Ziploc bags. But we did our surgery, and the patient brought their little jar to me. I said, what this jar is for? And they said, well, you'll find out, because after surgery, I'm supposed to put the specimen in the jar and give it back to them. Yeah, and then those are our actual table, and those are the table that we're trying to bring the patient up after surgery because she's feeling a little bit shortness of breath. And we can be pretty innovative, trying to do whatever we have. So, alrighty, see, this one is borrowed from Dr. Freddie Combs, breast anatomy. He already went through it. A lot of patients will tell us, oh, we have a lumpy, bumpy breast, but it's really not necessarily correlate with the dense breast tissue. But it makes physical exam very challenging for us because sometimes when we examine the patient, we don't know are we feeling the dense tissue or are we feeling the cancer lumps. And a lot of patients also, when they come to see breast surgeon, they're a little nervous. Oh, what do I have? Do I have something serious? But as breast surgeon, we actually take care of a lot of healthy patients with just normal benign disease. One of them is very common, called fibrocystic breast disease. And a lot of women during their reproductive period, and estrogen in your body will stimulate our breast. We have a gynecologist here, and I'm sure she can verify this. Estrogen will stimulate our breast, and sometimes we produce cysts. If you understand, colon may have polyps, and breast will have cysts. Fairly common. Those are not worrisome when they're small, simple, and also on the image, Dr. Combs earlier showed us one of the ultrasound. We can kind of tell what cyst looks like, the Charlie Brown face. So what do we do with the cysts when they become large? We can actually put a needle in there and take the fluid out, and that's the cure for the cyst. cysts. And also fibroadenoma is another common disease that is benign that we see a lot of. The youngest patient I actually did this one was 11 years old. I don't know about Dr. Cancel's record. And she just started developing breast, and all she did was form fibroadenoma. And remember, we had the 4-year-old boy that you drained the cyst too. Yeah. So fibroadenoma, sometimes on the physical exam, can be a little bit worrisome because it feels like a firm nodule. It's very scary, but in young women, they look like this when we take it out. Looks like a popcorn, and they have no risk for breast cancer. However, there is one type of sarcoma called Floyd tumor that in the breast can also be similar in appearance with a fibroadenoma. Hence, if a woman has a fibroadenoma, if it grows fast, or it becomes large, or if it's causing the symptom, for example, it can be right behind nipple. It can cause symptom even though it's small. We do recommend take it out because we cannot tell if it's a Floyd tumor or it's just a simple fibroadenoma. So mastitis, I see this a lot, and Hope Hospital's right here, and a lot of postpartum women and or during pregnancy and can develop mastitis. Mastitis typically we treat with antibiotic, or sometimes we can put aspiration, take out the abscess, and or sometimes we do need to do a small procedure to help the patient heal. The reason being that when baby is sucking on the breast milk, and they can introduce the bacteria, and that can cause mastitis. However, there is one type of breast cancer called inflammatory breast cancer. You will see a picture next. Can be similar in appearance with mastitis. So if mastitis is treated and it's not really getting better, maybe a sign that we should seek for specialty and to make sure the patient don't have inflammatory breast cancer. Okay, breast pain. I'm sure Dr. Cancel also see breast pain in the clinic. Sometimes it's really frustrating as a physician because sometimes it's really, there's nothing we can tell the patient that's actually anatomically wrong, and it could be related with hormone, and gynecologists probably see a lot of breast pain patient as well. And it could be just because of the diet and because of unfitting bra, and sometimes even related with this menses, and or could be a thyroid dysfunction. So breast pain, actually, the chances for cancer is actually very low. So if it's pain, or particularly the pains on both sides, the chances for that to be cancer related is actually very low. So sometimes it's good if it's just a breast pain, nothing else. But it is something we should be careful and do the workup according to the guidelines. Okay, so what are the unusual changes or signs for cancer? Those are actually in my patient's picture. If you look at this particular patient, all she has was a little skin puckering on the side, but her cancer is on the top. It's causing the skin pulling inside. This is the inflammatory breast cancer I was talking about. It looks like infection, but entire breasts are filled with cancer, particularly at the skin level. That's why the fluid is not able to go back and it appears to be red. This one, nipples retracted, and this one, nipples having what we call Paget's disease. This one came to us a little bit later, and she was actually not doing too well because the cancer was filled with her entire breast. And this one is pretty obvious. It's a big lump on the top of the breast. So only about 5% of breast cancer is start with the breast pain alone. This diagram, Dr. Combs already went through it, so I'm not going to waste too much time on those. The guidelines that Dr. Combs also mentioned, there are different guidelines, depends on what your primary care physician or gynecologist, because we have American Cancer Society guidelines, and National Comprehensive Cancer Network, and U.S. Preventative Service Task Force. Different guidelines have a different recommendation, but I do follow with Dr. Combs. We recommend it at the age of 40. The reason being that if you look at the cancer occurrence between age to 40 to 75, 74-ish, that's where most cancer happens. But younger than 44, there is still 10% of patients are diagnosed with breast cancer. And above age 75, about 25% patient is going to diagnose with breast cancer. And elder patient, which I agree with Dr. Combs, we continue screening patient as long as they are in good health, and also as as long as they're willing to, because 20% of patients are diagnosed at older than age of 75. But if you look at 35 of them will have mortality from breast cancer. So they don't do as good as the younger population. The risk factor, I think you went through that, and family history is probably one of the major risk factors. As a breast surgeon, we also do genetic testing, and we screen patient based on the guidelines. If patient has multiple family member with cancer, or some of the breast cancer are diagnosed at the younger age, or for example, male breast cancer, ovarian cancer, now even pancreatic cancer. So we go through patient's history and provide genetic testing. Genetic testing nowadays is a lot reasonable and affordable, and it takes 2 to 3 weeks. And nowadays, we can just do a spit test. If you can spit, you can do a genetic testing. And there are some new genes that I identified associated with breast cancer, BRCA1 and BRCA2. Angelina Jolie made this gene really famous. But there are also other genes that are associated with breast cancer, for example, TP53, PALB, CHEK2, and other genes as well. So those are risk factors. I'm not going to go over that anymore. Dr. Combs also mentioned about why did breast cancer happen? Patients always ask us. So one theory is cancer starts at the breast. So cancer cells start growing and then can travel to the blood vessel and can metastatic to somewhere else. But then the other possibility is theory number 2. What if the cancer cell has changed because genomically there's wrong information? So cancer cell can be starting somewhere else, but it start floating inside your body. It just happened to be dislodged on your breast, versus somebody else may be dislodged on their prostate or colon cancer, because some of the medication works for prostate cancer, may also work for breast cancer, and also work for pancreatic cancer. Is theory 1 or theory 2? Or is a combination? We don't know. Sometimes when you look at from outside towards inside, or maybe inside towards outside, breast cancer is very complicated. So if you look at the breast tumor biology, if you look at 100 women with breast cancer, they have 100 different kinds of breast cancer. Because if you look at different type, they're all different here. And if you also look at the breast, one particular cell, at the cell level, each cell has different receptors. We also look at the receptors, and there are different receptors to tell them there are different tumor biology. Sometimes I explain to patients, it's like looking at dogs. Sometimes it's big dogs, but they're very mellow. But sometimes it's small little chihuahua, they can be pretty vicious too. So breast cancer is really not one disease, but a group of biological distinct disease. And hence the reason why everyone's treatment is completely different. How come she got chemo? I don't get chemo. How come she got this surgery? I didn't get that surgery. How come she needs radiation? I don't need radiation. Why she's on this pill? I'm on the different pill. That's the reason why, because they're all different breast cancer. So breast cancer surgery can be disfiguring. That's what the surgery we were doing many, many years ago. Pretty barbaric. And the breasts were just chopped off like this. Chop, chop, chop. Everyone got the surgery. That's what the surgery that was been doing for many, many years. And that's what we were taught, right? I'm sure Dr. Cancel had learned that too. It's pretty disfiguring. But now if the breast cancer can be diagnosed early, and we have choices for patient. Patient can either have lumpectomy or mastectomy. My next few slides are going to be lots of picture of our actual patient, and I hope you guys don't mind. Okay, lumpectomy, this is the patient 1 week after surgery. We can do small, teeny, tiny incision. We can do surgery through a small, teeny, tiny incision. She had actually 2 phloidy tumor removed. That's the one I was telling, the fibroadenoma versus phloides. We cannot tell the difference. This is what she looks like 1 month after surgery. And then this is teeny tiny small cancer. We actually did the entire surgery through the nipple, and this is what she looks like after surgery. And you can't really tell the scar because we close like this. And this is the patient we did. This is her chemo port, and the surgery is actually on this side. And if you look at the scar, it's right over here, and she also have a lymph node surgery scar. So when the cancer is small, where it's treated, and then we can provide surgery, which is similar to this. But this one, we also were able to give patient a lift, and she came in with a very large breast on both sides, and the cancer was on the top. So we actually removed the surgery, removed the cancer, also gave her breast lift. This is 1.5 months after surgery. She feels much more smaller on the right side, and now she wants us to do the other side of the surgery now. Okay, that was all the picture for lumpectomy. What about picture for mastectomy? The mastectomy basically means we're going to remove the breast tissue. The picture you saw many years ago, the surgery was done removing entire skin, breast tissue, and sometimes even muscles. But when breast cancer is not diagnosed early, we have options to do immediate reconstruction, either with implant-based or tissue-based. And implant, that means we put a small plastic implant underneath the breast skin. So as a breast surgeon, when we do mastectomy, we'll try to save the skin as much as we can. And the tissue-based, there are two options too. Sometimes we give patients a tummy tuck and use the tummy tissue to rebuild the breast. And now there are plastic surgeons can also use the tissue in the back and reconstruct the breast tissue that way as well. So I have some of the pictures. This patient actually did a prophylactic mastectomy for BRCA mutation. So we did incision underneath here. So those are her two incisions. This patient did it for cancer treatment. So her chemo port is right here. This is the effect from the radiation treatment. So these are two implants, but you can tell radiation also distort the breast a little bit. So her left side of the breast after the radiation is slightly higher than the right side without the radiation. But overall, the skin incision is pretty good, and this is where her lymph node incision is. This patient, we saved the skin, but we cannot save the nipple because cancer is too close to nipple. As oncologists, we have to make sure we remove cancer treatments number one. Look, it's number two, right? So we removed her nipple, and she requests to have a matching procedure on the other side. That's her chemo port, that's her lymph node surgery, that's her drain. So those are some of the pictures for surgery. As a surgeon, I'm very proud and to show some of the picture, but I'm not the most important person on the table treating the breast cancer patient, because when the breast cancer is so large, this big, I cannot do surgery. And that's the reason why the medical oncologists, they actually provide precise medication to target each breast cancer and to treat the breast cancer so the cancer can be shrinked down to the size where I can do the surgery. Many years ago, chemo was just given after surgery. So the medical oncologist has really nothing to gauge what medication to give to the patient. It's one size fits all, right? Because cancer is in a jar. But now we have the precise medication. We can study the breast cancer and provide the medication that targeted to each different type of the breast cancer. So patient has great response. So we just did a mastectomy last week, and she had a triple negative breast cancer. By the time I do the mastectomy, on the specimen, there's no viable cancer left. And 15 lymph nodes I removed and no cancer left anymore. So the other things I want to give you a quick updates for radiation. Dr. Combs mentioned one-time radiation therapy. So in small cancer and in selected group of patients, we are able to provide one-time radiation because traditionally the whole breast radiation was given 4 to 6 weeks, sometimes even 7 weeks with 1 week of the boost dosage. And now when the cancer is small, now we can give radiation just right around the tumor bed, and then we can do the surgery, take out the cancer, put in the jar, and then we can radiate that area. And patient wakes up, and the surgery is done, radiation is done. And sometimes those patients don't need chemo, and most patients may just take hormone pill for 5 years. So I'm going to show you a quick movie slide. Thank you. Okay, so this is a small basically anatomy of the breast, a little cartoon picture. Imagine in the center, that's where the cancer is. So as a breast surgeon, we take out the cancer. So this is going to be after lumpectomy. So the cancer is removed. Now we're still in the OR table, and sometimes we can do the procedure without general anesthesia. So patient just needs some light sedation, and we can give them a lot of local numbing medication. And this little applicator brings the radiation into that field because the study has shown 90% of the recurrence probably going to be in that 1 centimeter rim of the tissue. Hence, the radiation to that area will decrease the chance of the recurrence. So that's how we give the radiation. And then after the radiation is given, then we do the recovery procedure, and we restore the breast tissue, and patient wakes up, and surgery is done, radiation is done. Okay, thank you.